Hello, my name is Dr. Brooke Rossheim. I'm a public health physician specialist with the Virginia Department of Health, and I'm going to provide a monkeypox overview for healthcare providers. So this is going to be an overview that will cover a number of different topics regarding monkeypox, and this is really geared toward primary care providers overall. Next slide. So the outline is we're going to talk about general monkeypox overview, clinical assessment and evaluation of a patient suspected of having monkeypox, infection prevention and control for monkeypox in a healthcare setting. We're going to talk about monkeypox testing, monkeypox vaccination, and monkeypox treatment and patient management. You will receive a copy of the slide deck, and there will be clickable links in the slide deck. And so there's a couple of good resources for clinicians at the bottom. You can see there are two bulleted points. One is a CDC document, one is a VDH document about monkeypox for healthcare professionals. Next slide, please. So let's go ahead and go with the overview of monkeypox. So monkeypox is caused by the monkeypox virus. This virus is in the same family of viruses as smallpox, which is the orthopox virus family. And there are two what are called clades of monkeypox. Clade 1 tends to cause more severe illness, and clade 2 is the monkeypox virus that is causing the current global outbreak. The symptoms of monkeypox are similar to smallpox, but the illness is milder, and monkeypox is rarely fatal. Also, monkeypox is not related to chickenpox. Next slide, please. So let's talk about the epidemiology of the 2022 monkeypox outbreak. This obviously is a multinational outbreak. In a recent MMWR issue, this was from several months ago, about 99% of cases of monkeypox have occurred in men, about 94% of whom reported recent intimate or sexual contact with other men, and about 41% had HIV infection. As of October 20, 2022, there have been 4 fatal cases of monkeypox in the US. And as of October 20, 2022, in total, there are 75,166 cases of monkeypox reported from 109 countries around the world. And there are 27,835 cases across the US. Next slide, please. So looking at some data in Virginia, as of October 20, 2022, there have been 521 confirmed cases, 22 hospitalizations, no deaths. 94% of the cases have been in men. And you can see that this is mainly in young to middle-aged groups. So 20 to 29 years, 30 to 39 years, those are the two biggest categories where we're seeing monkeypox. The majority of people have reported their race or ethnicity as Black, followed by white, and then Latino as far as the number of cases. You can see the epidemic curve on the left-hand side, and you can see that we hit a peak of cases in roughly about the middle of August. And since then, the case counts have been going down. And then you can see that gray bar over on the right-hand side, which indicates uncertainty. So that's very new data. And obviously, we don't know what the future trajectory of monkeypox will be, but we can see that the number of cases are going down, is going down. So next slide, please. So let's talk about the transmission of monkeypox. The main mode of transmission is close contact with rash lesions or body fluids. And this can occur during intimate contact. Now, one thing I do want to note is that intimate contact could be sexual contact, but it can also be non-sexual intimate contact. For example, one way that a child could get monkeypox is if a parent or someone holding the child has a monkeypox lesion that rubs up against the skin of the child and nothing sexual at all happened. So the transmission of monkeypox does not necessarily need to be by sex. Monkeypox can also be spread via contaminated materials, such as monkeypox lesions contaminating bedding or towels, or also via respiratory droplets. Most cases of monkeypox are in people who identify as men who have sex with men, or MSM. However, I do want to stress that anyone can get and spread monkeypox through close contact. So it does not necessarily have to be between men. It can be between really anyone. So this is not an illness that is confined or limited to men who have sex with men. That's a really important point. We are seeing that cases in females are gradually increasing. And again, it is possible for children to get monkeypox through nothing sexual at all. The incubation period of monkeypox, that is the time between exposure, the person was exposed to the illness, to when they could develop symptoms of the illness, is pretty broad at 3 to 17 days. So that's kind of a wide incubation period. When it comes to monkeypox, people are considered infectious from the time of symptom onset until all the skin lesions have scabbed over, those scabs have fallen off, and new healthy skin has formed over the site. So that is the definition of when someone is considered infectious and when they're not infectious. And currently it's unknown whether HIV infection alters a person's risk of acquiring monkeypox after they have been exposed to it. Next slide. There are a number of things that we just don't understand about monkeypox and that research is being done about. So one thing is if this virus can spread when someone has no symptoms of the illness. Another is about the respiratory route. How often does monkeypox spread through respiratory secretions, or when a person with monkeypox symptoms might be more likely to spread the virus through respiratory secretions? What is the extent of spread through contaminated objects? We've already talked about the fact that objects can become contaminated. This is a way that people can get monkeypox, but we need to learn more about it. And also we need to learn whether monkeypox is efficiently spread via semen, vaginal fluids, urine, or feces. Next slide, please. So now we're going to talk about the clinical assessment and evaluation of a patient with suspected monkeypox. Next slide. So these are clinical features. So as is pretty typical with a lot of viral illnesses, monkeypox can present with a viral prodrome. That would be fevers, chills, headache, muscle aches, joint aches, pain in other areas, fatigue, enlarged lymph nodes. And the interesting thing about the prodrome is that usually it would happen before the illness, before the rash. But with monkeypox, the prodrome can be present before the rash. It can also be present after the rash starts, or it can just simply be absent altogether. Typically with monkeypox, you'll see a rash about 1 to 3 days after the prodrome. Oral lesions are common, and then cutaneous lesions are pretty common as well. And these cutaneous lesions tend to progress in a fairly orderly way, going from macules to papules to vesicles, then to pustules, and then the lesions scab over. And then obviously we're waiting for the scab to fall off and new healthy skin to take its place. Generally, monkeypox is a self-limited illness, and it lasts about 2 to 4 weeks. However, the lesions can be quite painful and itchy and just be uncomfortable in general. CDC does have a webpage that you see a link to about monkeypox. In patients, in people with HIV, the signs and symptoms of monkeypox virus infection are similar in people with or without HIV. So far, there hasn't really been a real distinction in terms of symptoms or signs. Data do indicate, however, that patients with advanced and uncontrolled HIV disease can be at higher risk for severe monkeypox infection. And really, this is true for anyone who is immunocompromised overall. So really, regardless of the cause of immunocompromise, whether that's from HIV, whether that's from cancer chemotherapy, whether that's from medication that might have an effect on the immune system, et cetera. So next slide, please. So as far as the rash characteristics, you'll see the monkeypox rash described as well circumscribed, firm, deep-seated lesions. These lesions often will develop umbilication, and that may be one tip-off that you're dealing with monkeypox is the umbilication. The lesions are often in the genital and anorectal areas or the mouth. The rash does not have to be disseminated. The rash may only consist of a few lesions, or it can even be a single lesion. The rash of monkeypox can look like other things, like herpes, like syphilis, like chickenpox. So it can be confused with other illnesses. Next slide. So one thing that we focus on is how to distinguish monkeypox from other illnesses that it looks like. Certainly, as we've talked about, monkeypox can be confused with other sexually transmitted infections or STIs, especially if the rash is in the genital area. Now, a diagnosis of an STI does not exclude monkeypox infection. There have certainly been reports of patients who have both monkeypox and another STI. So when evaluating a patient, some things to note. So you want to get a good history of present illness. Has the patient had a viral prodrome? What has been the progression of the rash? What kind of characteristics about the rash? Are these lesions painful or itchy? These may be tip-offs that you're dealing with monkeypox. Social history is important. Has this patient engaged in, risk behavior? So obtaining a sexual history from the patient is important. A thorough physical exam, looking for a centrifugal rash distribution. That would be a rash concentrated on the face, arms, or legs. And also, are the lesions in the same stage of development in an area? That would be another tip-off that this might be monkeypox. We've talked about umbilication. And then, patients who have a new rash, who have epidemiologic criteria that would make you think about monkeypox. and in whom there is a high suspicion of monkeypox. These patients you really want to test for monkeypox. Next slide. So we mentioned epidemiologic criteria. So let's talk about that a little bit more. CDC has some epi criteria that would give you an indication that you might be dealing with monkeypox. So is the patient a close contact with someone with a rash or who received a diagnosis of confirmed or probable monkeypox? Has this person had sexual contact with individuals in a social network where there is monkeypox activity going on, where one of the members or more than one of the members has monkeypox? Has this person traveled to a country with recent monkeypox cases or outbreaks? Another epi criteria would be an animal exposure with a live or dead wild or exotic animal that is an African endemic species. This is probably a more unlikely criteria, but it is one to think about. So if we think our patient has monkeypox, we want to isolate our patient. That is the first thing we want to do. And we want to use standard and transmission-based precautions, and we will talk about that in a minute. We want to contact the local health district or health department immediately to report either a suspected case or a confirmed case. So please remember that if you have even a suspected case of monkeypox, that is a rapidly reportable illness to the health department. And so, and what we recommend is that you simply call your local health department, because that is really the fastest way to report that you have a suspected case. And that way the health department can start doing the things that they need to do. And you have notified the health department. You can also submit a confidential morbidity report through the portal, and you see the link there. We've also put in the slides a local health department or LHD locator, so that will show you all the health department locations in the state. And of course, you want to test the patient for monkeypox and other illnesses. Next slide. So these are resources that you can use for clinical assessment and evaluation. Some of these are VDH, some of these are CDC, but there is a lot of good information. I will put a plug in for the bottom reference, the CDC COCO webinar, What Clinicians Need to Know About Monkeypox. It's a really good webinar and contains a lot of good information. Next slide. So let's talk about monkeypox infection prevention and control in a healthcare setting. Next. So if we have a person who we suspect has monkeypox, or we have a person in whom monkeypox has been diagnosed, we want to isolate that patient in a single room. So that could be a single exam room in a doctor's office, that could be a single room in an ER, that could be a single room in a hospital. Special air handling, so a negative pressure room, is not required. The patient should be masked, and lesions should be covered if the patient is in some kind of a shared space. Now, when it comes to personal protective equipment for healthcare providers, or HCP, we recommend, and CDC recommends, use of standard and transmission-based precautions. This would be a gown, gloves, an N95 respirator or higher, and eye protection, and that could be goggles or a face shield. Any procedure that is likely to generate oral secretions, such as intubation, suctioning, extubation, this should be performed in an airborne infection isolation room, or as it's also known as a negative pressure room. Everybody in the room should be wearing full PPE, and especially including an N95 respirator. you want to avoid activities that may spread material from these lesions. So when soiled laundry is being handled, you don't want to sort of shake it around or, handle it in a manner that's going to perhaps disperse infectious material. Remember these monkeypox lesions, they may weep, they may be vesicles that may burst. So you're going to have, it's possible that material could be flying around a little bit. You also want to avoid the use of portable fans, dry dusting, sweeping, and vacuuming for really the same reason. You don't want these materials flying around in the air. Next slide. So when testing for monkeypox, you want to collect specimens following the CDC's Infection Prevention and Control, or IPC, guidance. CDC has a nice page about this. As far as waste, it should be handled according to the U.S. Department of Transportation hazardous materials regulations and state and local regulations. So right now, the monkeypox cases that we are seeing are clade 2, as we talked about earlier. And with clade 2 monkeypox, this patient waste can be handled as regulated medical waste. So that means that everything that's going to be thrown out goes into a red bag, a biohazard bag. Sharps obviously go in a sharps container. And so basically you would follow the same procedures as for other regulated medical waste. Now, if there's some reason to suspect that a patient may have clade 1 monkeypox, so for instance, if a patient had exposure to clade 1 monkeypox, then the waste needs to be handled as category A medical waste, which is more intensive. It requires more bagging of materials, so maybe not 1 bag, but 2 bags. And so that is something that if you think that you're dealing with clade 1, that would be category A waste, and that is handled in a more strict manner than regulated medical waste. Next slide. So let's talk about monkeypox transmission in a healthcare setting. Exposure can occur to healthcare providers through needle sticks, a needle stick injury from a patient with monkeypox or someone who is suspected of having monkeypox, direct contact with the specimen or skin lesions, or aerosols generated in a laboratory. So therefore, healthcare professionals collecting specimens should wear gloves, gown, an N95 respirator, and eye protection, just like we talked about before. One important thing is that there is no need to de-roof or unroof a skin lesion to collect a specimen. This can lead to unnecessary exposure of the healthcare provider to a lesion. There is actually a recent case of a nurse in Florida who acquired monkeypox via a needle stick after using that needle to puncture a monkeypox lesion. So we just want healthcare providers to be careful, especially when they're using sharps in terms of not exposing themselves to monkeypox. Next slide. So let's change a little bit and talk about infection prevention and control practices in a non-healthcare setting, such as a home. So CDC recommends that people with monkeypox isolate at home or another location for the duration of the illness. And this applies to adults and children. As we talked about before, current data suggests that people are contagious from the time symptoms begin until all the lesions are fully resolved and all symptoms are resolved. Now, this can take a while. So this could be an isolation duration of 2 to 4 weeks, and sometimes it could actually be even more than 4 weeks. Next slide. So if patients are not able to isolate fully for the duration of the lesion, for the duration of the illness, CDC does recommend the following. When the patient is symptomatic with fever and any respiratory symptoms, they should remain isolated. Patients are advised to avoid close or physical contact with other people or animals. We want patients to cover the skin lesions, wear a well-fitting face mask, and avoid public transportation. If a rash persists in the absence of fever or respiratory symptoms, it's recommended that the entire rash be covered with clothing, gloves, bandages. We also want patients to wear a well-fitting mask to prevent any spread of respiratory secretions. Again, the idea is really that, we really want people to isolate when they have active, monkeypox illness and when they are contagious. So that's sort of the big take-home message. But if they cannot, these are some options for them. Next slide. So other things that patients should be advised about, that until all signs and symptoms of monkeypox illness have fully resolved, patients should not share items that have been worn or handled with other people or animals. You want to launder or disinfect items that have been worn or handled. You also want to disinfect surfaces that have been touched by a lesion. We've already talked about avoiding close physical contact. This could be sexual or non-sexual contact with other people. We don't want people to share utensils or cups or other things. Patients should avoid crowds and congregate settings, and patients should wash their hands often with soap and water. And if soap and water is not available, use an alcohol-based hand sanitizer, especially after direct contact with the rash. Next slide. And these recommendations about infection prevention and control can also apply to the workplace. CDC does have a nice website for workplaces and businesses that I would encourage you to take a look at. And CDC also mentions some other things that employers can do in a workplace setting. So one is to ensure that workers with monkeypox follow the isolation practices so that they are isolating. And another thing is to offer telework or flexible non-punitive sick leave to workers with monkeypox. Next slide. And so again, in a non-healthcare setting, such as a home, you want to routinely clean and disinfect commonly touched surfaces and items. Now, EPA has a list of disinfectants. This is in list Q that lists disinfectants that are likely to be effective against special pathogens like monkeypox. For patients with monkeypox, you want to avoid the use of contact lenses to prevent the inadvertent infection of the eye. People with ocular monkeypox, that is brings its own set of issues. People should avoid shaving rash-covered areas of the body because it is possible to spread the virus around a person's own body. Regarding bathroom usage, if it's possible, we would like the patient with monkeypox to use a separate bathroom if there are other people who live in the household. If there is not a separate bathroom in the house and there are other people, the bathroom should be cleaned and disinfected, particularly the surfaces that are touched, such as countertops, toilet seats, faucets, using an EPA registered disinfectant. So we go back to list Q. And And this would include activities like showering, toileting, changing bandages that are covering the rash, etc., where surfaces could get contaminated. Another thing to think about is using disposable gloves. So the person with monkeypox could consider disposable glove use while cleaning if the rash is present on the hands or just in general. You certainly want to try to limit contamination with the household. So for upholstered furniture, you want to try to avoid contaminating that by covering those things with sheets or waterproof mattress cover, blankets, tarps, something so that an upholstered surface, which could be difficult to clean, is not contaminated. Next slide. So these are infection control resources. These do contain good information and are pretty comprehensive. Next slide. So we're going to talk about monkeypox testing. Next. So now there are multiple labs that offer multiple commercial labs that offer monkeypox testing. They used to be done exclusively by CDC. So Aegis, LabCorp, Mayo, Sonic Healthcare, and Quest all provide monkeypox testing, whether they use CDC's test or Quest uses its own test. These are tests that look for these are tests to detect non-variola, so non-smallpox, orthopox virus DNA. The tests are not free. The out-of-pocket costs can vary from patient to patient. So that's something, to call the lab about regarding if there's going to be a cost to the patient. Again, I recommend that you look at the lab information for each lab about what kind of specimen they want, how they want it collected. Some labs differ a little bit from others. It is possible that positive specimens may be sent to CDC for additional characterization. That doesn't always happen. And the thing is that if the test at one of these labs is positive, that is a positive, it's an actionable result. That's a case of monkeypox. Now, the Division of Consolidated Laboratory Services, which is the state public health lab, does offer lab testing, but only in certain criteria. And you can see there's a link to the clinical and epi criteria. The other thing with DCLS is that it's not a commercial lab. And so, pre-approval by the local health department is required. Typically, this is going to be more in an outbreak setting. One thing, and as you can see, these areas are highlighted, indicating special importance. Patients who are suspected of having monkeypox or who have monkeypox should be tested for HIV and other STIs. So it should not be just testing for monkeypox alone, because there is such a high concordance with HIV and other STIs. So examples of other STIs to test for would be gonorrhea, syphilis, herpes, chlamydia, and anything else that you, the clinician, feel should be tested for. Again, any suspected case should get reported to the local health department. This is a rapidly reportable illness, so the best thing to do is a phone call. There are other ways to report. You can use the confidential morbidity report online, but a phone call is really the best way to go. And that's even if the testing is being conducted at a commercial lab. Next slide. Specimen collection, we've talked about this a little bit. You definitely want to wear appropriate PPE. We've talked about what that consists of. You want to collect material from the surface of the lesion or crust from a healing lesion. Typically, and again, this may vary a little bit by lab, so you want to see what each lab says. Typically, it would be, 2 swabs per lesion, and 2 or 3 lesions might be swabbed. And that's usually sufficient right there as far as testing for monkeypox. You do not want to use cotton swabs. So the swabs you want to use are ones that have a plastic, wood, or thin aluminum shaft. You do want to swab the surface of the lesion vigorously to collect adequate DNA. I will say that all of these tests that are done at the labs, the PCR tests, are quite sensitive. So, they will pick up DNA, high sensitivity testing. As you can see, I've highlighted there's no need, and CDC does not encourage people to de-roof or unroof or lance lesions before swabbing, because what that can do is that can generate fluids, because if you're trying to lance a vesicle or put a needle into a vesicle, and fluid can splash, and this can lead to inadvertent infection of healthcare providers. Next slide. So if a patient tests positive, this is an actionable result for clinical and epi purposes. As we've already said before, it needs to be reported to the health department. If the patient has not, remember, a suspected case should be reported. So if you haven't already reported this to the health department, please report now. You want to evaluate the patient for treatment. We're going to get to treatment in a little bit. And then, you want to counsel the patient about a number of things in terms of notifying close contacts, that the patient should stay home, isolate except for emergencies or medical care, stay away from others in the home, including pets, avoiding contact with others, including sexual contact, wear a mask if they have to be at home around others. Do not share items that could become contaminated, no contact lenses, and washing hands frequently, soap and water or alcohol-based hand sanitizer. Next slide. So this is a chart, and really just to provide you with an overview of the labs that are currently doing monkeypox testing. I've looked at all of these links, and they are all good. They all work. We've given you some of the test codes where we had them, the expected turnaround time, and then you can see some additional information for Quest and LabCorp regarding how they want specimens collected. So again, please consult the lab information as to how they want a particular specimen collected. Next slide. And here are resources about testing, and you can see there's CDC resources and NETEC resources as well. There are videos about how to collect a specimen, and those are pretty good. Next slide. So let's talk about monkeypox vaccination. Next. So right now we have 2 available vaccines for preventing smallpox and also monkeypox. The first is janaeos, and that is how that is pronounced. This is a live attenuated vaccinia virus vaccine that is replication deficient. It is not capable of replication. And what we're using here is essentially cross immunity. The vaccinia virus is in the same family of orthopox viruses as monkeypox. Right now, we do not have a specific monkeypox vaccine that is based off of just the monkeypox virus alone. So what we use is cross immunity to the vaccinia virus. So janaeos was approved in 2019 by FDA for prevention of smallpox and monkeypox for adults. Now, what has happened recently is that FDA has issued an emergency use authorization, an EUA, for the vaccine to be used in children, so less than 18 years old. And also they've issued an EUA for this vaccine to be used intradermally. The original janaeos vaccine is a subcutaneous vaccine of 0.5 ml that is given subcutaneously. One of the things is that the supply of janaeos is limited, and so it has been found that you can give, and this is in adults, that you can give 0.1 ml intradermally, and that it produces roughly the same level of antibodies as giving 0.5 ml subcutaneously. So there is an EUA out there that allows adults to be given an intradermal injection with the janaeos vaccine. And if you're wondering, yes, the intradermal injection is the same way that a tuberculin skin test is given. So this is the same thing. Now, one thing I do want to mention is that if you are not familiar with doing intradermal injections, please reach out to the health department. Please reach out to us, because we can help you in that regard. We can offer training about doing intradermal injections. This is kind of a skill in and of itself. And so that is something we can help with. The other vaccine is ACAM 2000. This is another vaccinia virus vaccine, and this is a live replication competent vaccine. So this is one where the vaccine can cause vaccinia illness on its own if it is not handled properly. Right now, we are not, as you can see in that red box below, currently janaeos is the primary vaccine being used in Virginia, and that's correct. Right now, we are not using any ACAM 2000. People may remember or may be familiar with ACAM 2000 because it was licensed in 2007 as a vaccine for people at high risk of smallpox. And when you use ACAM 2000, you use a bifurcated needle, and then what you do is you jab the person 15 times over the deltoid muscle. It is not an intramuscular injection. What you're doing is just jabbing the skin over the deltoid. And so, people may remember the older Dryvax, which was a previous smallpox vaccine that has now been replaced by ACAM 2000. So ACAM 2000 is not approved or authorized by FDA for use for monkeypox prevention. So if ACAM 2000 needed to be used, then it would have to be used under either FDA would have to issue an EUA, an emergency use authorization, or it would have to be used under an expanded access investigational new drug protocol. That is a thing unto itself. We'll actually talk about that a little bit later. ACAM 2000, because it is replication competent, should not be given to people with HIV regardless of their immune status. Next slide. So janaeos is a 2-dose vaccine series separated by 28 days, 4 weeks. The person is considered vaccinated 2 weeks after the second dose. For people who've had ACAM 2000, they know about the take, that you have to have a little evidence of inflammation at the site of the where the person is jabbed with ACAM 2000. With janaeos, there is no take, if you will, so there is no risk with janaeos of spreading vaccinia virus to other parts of the body or to other people. So therefore, if healthcare providers are giving janaeos, there is no requirement for them to be vaccinated themselves if they don't want to be vaccinated. So really the only contraindication for janaeos is a history of a severe allergic reaction to a previous dose. You can see that there are a couple of precautions regarding janaeos, but This is a vaccine that really does not come with the same amount of nearly the same amount of precautions and warnings as ACAM 2000. And janaeos is safe for most immunocompromised people, and that would include people with HIV disease that's advanced or AIDS. Next slide, please. So this is a little table describing the janaeos emergency use authorization. I will not go through the whole table because it's here for you, but you can see that there is the intradermal route of injection, there's a subcutaneous route of injection. One is the intradermal is referred to as the alternative regimen, the subcutaneous is referred to as the standard regimen. And then you can see below, there are really two exceptions to intradermal administration of janaeos. One is if people have a contraindication to an intradermal injection. And really at this point, that would be people who have a history of keloid formation, or those people who just simply cannot tolerate an intradermal injection. And the other reason for no intradermal injection would be for children, those under 18 years. Next slide. So this is a graphic that CDC put together about how you give intradermal janaeos. This is the same way that you would give a tuberculin skin test. And so you can see a nice graphic. And then if you look at the bottom left-hand corner, I've put a couple of links. CDC has a nice video about giving an intradermal injection. And there's also, I put a link to a YouTube video, and there are actually a few YouTube videos about giving an intradermal injection. So I picked one of them and put the link on the slide. Next slide. So as far as vaccine effectiveness, essentially, really, we are collecting that data now. So we do not have data yet about yet available about the effectiveness of the vaccines in the current outbreak. We also do not know the duration of protection from the vaccines, or if this protection does wane over time. So CDC is working with its partners to collect data on vaccine effectiveness, vaccine safety, and this is information that will be coming out probably, I would hope in 2022 that this comes out. The peak immunity regarding janaeos is 2 weeks after the second dose of janaeos. With ACAM 2000, if we ever got to the point of using ACAM 2000, currently we are not using it. That would be 4 weeks after vaccination with ACAM 2000. We've already talked about steps that people should take to protect themselves and to protect others. So I won't go through those bullets. That would be another other measures for infection prevention and control. Next slide. So one of the things that we do have available to us is post-exposure prophylaxis against monkeypox. The goal, we refer to this as PEP. The goal of PEP is we're going to use janaeos, the vaccine, to vaccinate people following a known exposure to help prevent monkeypox illness or minimize the severity of the illness. Now, we have to use the vaccine, janaeos in this case, fairly quickly after the exposure. So the goal is to give the vaccine within 4 days of the exposure. That's really our best chance to prevent the onset of monkeypox. If we give the vaccine later, that is between 4 and 14 days after exposure, the vaccine may be effective in reducing the symptoms of monkeypox, but it may not prevent the illness. So Post-exposure prophylaxis is important because it helps to stop the transmission, the further monkeypox, so that we don't, hopefully, we can help control an outbreak, so that it doesn't get worse. Now, an important point about using janaeos. If a patient has already been diagnosed with monkeypox, so if they already have that diagnosis, then PEP is not indicated. Then there's no indication to give them a janaeos vaccine. The reason for this is that CDC feels that natural infection with monkeypox is going to produce fairly good immunity. And so at this time, CDC does not recommend using janaeos for post-exposure prophylaxis if someone has already been diagnosed with monkeypox. Now, we have another situation. What if a person has had the first janaeos vaccine and then they get monkeypox before the second dose of janaeos? Should they get that second dose? The answer is no. At this point, CDC does not recommend that the person get that second dose of janaeos because, again, they feel that natural monkeypox infection is probably going to confer pretty good immunity. Next slide. We have another thing called expanded PEP, or PEP++. So the goal of this is basically to vaccinate people who are at high risk of developing or acquiring monkeypox, even if we don't know if they've had a documented or confirmed exposure. So we are vaccinating, so we are using the vaccine in people who are in high risk groups. And currently we've got 5 high risk groups who would be eligible for expanded PEP. That would be people of any sexual orientation or gender who have had anonymous or more than one sexual partner in the last 2 weeks, or sex workers of any sexual orientation or gender, or staff of any sexual orientation or gender at establishments where sexual activity occurs, like a sex club or something like that, or people of any sexual orientation or gender who are living with HIV/AIDS, or people of any sexual orientation or gender diagnosed with any STI in the past 3 months. So those are the current groups that are eligible and recommended to get the janaeos vaccine under this expanded PEP criteria. We have mentioned that people living with HIV or other immune compromising conditions may be at higher risk for severe outcomes, and we would like these people to be higher priority for vaccination. And Virginia continues to look at categories and evaluate, people in whom janaeos would be beneficial as far as expanded PEP. And so we've got the website to the VDH healthcare providers vaccine webpage. Next slide, please. And then we have pre-exposure prophylaxis. So pre-exposure prophylaxis is the typical reason that we would give a vaccine basically to people who are at risk of coming down with the illness. In this case for pre-exposure prophylaxis, or as we refer to it as PrEP, the goal is to vaccinate people whose jobs might expose them to orthopox viruses such as monkeypox. So at this time, CDC's recommendation is that most clinicians and laboratorians are not advised to receive PrEP. However, having said that, there are a few groups that would be eligible, may be eligible, to receive PrEP based on CDC recommendations. This would include clinical lab personnel who specifically perform testing to diagnose orthopox viruses, such as PCR testing, research laboratory workers who directly handle cultures or animals contaminated or infected with orthopox viruses that infect humans. In certain designated healthcare and public health response team members for preparedness purposes. So for example, if you are a healthcare worker who is going to work with patients if they have monkeypox, that you would work with those patients, that would be a reason to get pre-exposure prophylaxis with janaeos. Another thing, if you are someone who is going to administer ACAM 2000, while it is not required that you get immunized with janaeos ahead of time, it is not a bad idea because ACAM 2000 is replication competent, and you want to make sure that you don't inadvertently infect yourself while giving ACAM 2000. Now, currently, like I said, we're not using ACAM 2000, so that's not really an issue, but that would be an example of a reason to give someone pre-exposure prophylaxis with janaeos. Next slide. So if you are a provider who wants to administer janaeos, I won't read through the whole slide, but there are a number of things that you need to do. Right now, janaeos is mainly being administered by the health department, but we would certainly like to get other providers on board with administering janaeos vaccine. This is kind of similar to COVID vaccines, where because this is under an emergency use authorization, there is an HHS provider agreement. There are other things that you have to do to administer janaeos, and they're listed on this slide. But again, we would like to expand the number of people who are giving the vaccine because this makes it easier for patients to get janaeos, whether it is being used for post-exposure prophylaxis, PEP, or pre-exposure prophylaxis. Next slide, please. Obviously, there are lots of resources on vaccines. You've got resources about pretty much everything about janaeos, about the administration of the vaccine, what to do if errors happen, a lot of FAQs. Next slide. So now we're going to talk about monkeypox treatment and patient management, and this is the last section of the slide deck. Next slide. So like we said, most people with monkeypox have a mild self-limiting illness, and they really do not require any specific treatment other than supportive care. And right now, we do not have any drugs that are specifically approved for the treatment of monkeypox virus. But we do have drugs, we do have antivirals that are used for smallpox that may help people with monkeypox. So people who you would consider treatment in would really be in one of three categories. So the first would be people who have severe disease. They have hemorrhagic disease. They have lesions that are so large that they are becoming confluent. People that have monkeypox that's affecting other organs so that they're septic. They have encephalitis. They have ocular monkeypox, or other conditions where they need hospitalization because they have a level of illness that requires it. Another reason, people who have monkeypox involvement of anatomic areas, which might result in more serious sequelae of monkeypox disease. So as an example, monkeypox illness can leave behind scarring or strictures. So if you have people who have monkeypox of the urethra, the penile foreskin, vulva, vagina, the rectum, the bowel, places where you would not want a stricture formation to happen or scarring, then that would be another reason to look at treatment medication. The third category would be people who are at high risk of severe disease. So people who have immunocompromising conditions, including patients with HIV or AIDS or any other illness that is immunocompromising. Patients less than 8 years would fall into this category. People who are pregnant or breastfeeding would be in this category. And also people who have a condition affecting skin integrity, such as atopic dermatitis or burns, something like that would be in that category. Next slide. So the preferred antiviral is a drug called tecovirimat, and its brand name is TPOXX. So generally we refer to it as TPOXX. TPOXX is available through the Strategic National Stockpile, which is a federal government asset, and it is available under an expanded access IND, Investigational New Drug Protocol. This is basically also known as compassionate use. You can see in the chart, I've put some information about TPOXX and what it's used for, how it comes. It comes as both an oral capsule that is 200 milligrams and also as an injection. Most of the time, TPOXX, if it's used, is used as an oral medication. Now, there are some additional, and then you can see links to TPOXX. There are other antivirals that can be used. Cidofovir, which is a drug for cytomegalovirus retinitis in patients with AIDS. This can be considered for use in severe monkeypox cases. Vaccinia, immune globulin intravenous. This is also known as VIGIV. This is another drug that can be used in more severe cases. And there's also a drug known as brincidofovir that is under development. It is not available just yet. This is another drug that can be, that when it becomes available, may be able to be used. Next slide. So let's talk a little bit about TPOXX. So TPOXX is an FDA-approved drug for the treatment of smallpox, not for monkeypox. So TPOXX's FDA approval is for treatment of smallpox in adults and children. The data on effectiveness of TPOXX in treating monkeypox in humans are really not available. We do have animal studies showing that the drug is effective in treating diseases caused by orthopox viruses. And there is a case series that is published in Lancet in which they took patients who had monkeypox virus illness, and one patient was treated with TPOXX or tecovirimat, and the paper suggests that tecovirimat may shorten the duration of illness and viral shedding. The clinical trials with TPOXX are essentially going on now, and that's what's happening. So far, we have not seen any really bad side effects. You can see the common adverse reactions with oral TPOXX, headache, nausea, abdominal pain, vomiting. There are a couple of drug-drug interactions that are potential with TPOXX, with repaglinide, which is an anti-diabetic, and midazolam, which is a Versed, a sedative. And one thing to note that is, if there is an appropriate clinical indication, empiric treatment with TPOXX can be considered prior to lab confirmation of monkeypox, especially in the context of limited testing or if the testing is really going to be delayed. Next slide. So, considerations with TPOXX, we want clinicians and patients to understand that there is a lack of data about effectiveness. There's a lack of data regarding which patients might benefit the most. There is a concern about resistance developing to TPOXX. TPOXX, it is written that TPOXX that is susceptible to resistance, so that's another issue. One of the things is we want to avoid the indiscriminate use of TPOXX when it's not needed, so that resistance does not develop. Next slide. So if you want to obtain TPOXX, if you want to use it for your patient for the treatment of monkeypox, you have to follow the following steps in order to get it. I won't go through this entire slide because I think the slide really speaks for itself. But TPOXX is available under an expanded access investigational new drug protocol. And so these things on the slide have to be followed, but you can get TPOXX for your patient. It is available. In some hospitals in Virginia, TPOXX has already been pre-positioned, so they have a supply of this medication already. Next slide. So as far as about supportive care for the patient, you want to educate the patient on the natural course of monkeypox and isolation and infection control practices. Most patients with monkeypox do have a mild self-limited illness, but we want to take care and assess and take care of those symptoms that are bothersome to the patient. Basically, supportive care would be, good fluid intake, pain management, treatment of any kind of bacterial superinfection of a lesion, treatment of any STI if a patient has an STI, and supportive care in patients sometimes can get complicated. Excuse me, and some patients may require hospitalization for treatment of dehydration, severe pain, or complications of monkeypox. Next slide. So when it comes to pain management, these lesions of monkeypox can be painful. They actually can be quite painful. So these could be oral mucosal lesions. These could be lesions in the genital area, the anorectal area. So for general pain control, think about over-the-counter medications such as Tylenol or NSAIDs. For local pain control, you can think about topical steroids and anesthetics. It is important to remember that if you're using a topical lidocaine, that you want to be careful about using it on areas of broken skin or open or draining wounds, because lidocaine can get absorbed systemically to a greater degree, and you can get side effects of lidocaine. Obviously, prescription pain medicine is going to be in the consideration mix. Gabapentin has been put forward, and certainly if patients need short-term opioid therapy, that would be appropriate. Obviously, you want to consider the risks and benefits of opioids, discuss them with the patient before prescribing them. And as we said, appropriate pain control may require hospitalization in some cases. Next slide. You want to instruct the patient to monitor skin lesions for any sign of bacterial superinfection. So if the lesions become red, warm, purulent, patients may have pruritic lesions where you can use oral antihistamines. You can also use some topical agents that are shown on the slide. Patients may have oropharyngeal lesions where you can use saltwater gargles several times a day. You can use oral antiseptics like chlorhexidine mouthwash. Also, you can use magic mouthwash, which contains analgesics in it. For genital and anorectal lesions, doing sitz baths periodically can help with discomfort. Next slide. And then these are treatment resources, from CDC about for patients with monkeypox. I do want to highlight this last part, that CDC does have a clinical consultation line, and this is 24/7. And so if you have a case of monkeypox, whether it's regarding diagnosis of monkeypox, whether you're treating a patient with monkeypox and things are becoming complicated, the clinical consultation line is available, and I encourage you to use it. The number is down below. This is available. They will walk you through the process of treating patients. On lots of CDC calls, they have mentioned that they encourage clinicians to call the clinical consultation line if they need assistance with more complicated cases of monkeypox. And the next slide. So I know that that's a lot of information that we've covered and a lot of slides. I want to thank you for your attention. If you have any questions, please feel free to send them to us at VDH, and we will do our best to answer them and get back to you. Thank you very much.